the pediatric grand rounds. If I could remind folks to please log into the CME system, that helps us track attendance. Even if you're not claiming CME, it really helps with continuing this lecture series and hopefully purchasing food at some point this fall. So today is my pleasure to introduce Dr. Nichols. Sarah Nichols is one of our third-year residents. Before joining us here at ETSU, she earned her Bachelor of Science in Biology at LMU and went on to earn her DO at LMU as well. She's engaged in numerous scholarly activities while here at ETSU, including a lot of work on the constipation pathway in the hospital, which is an awesome quality improvement project. Dr. Nichols also has numerous volunteer activities, including the Scarecrow Skedaddle and Angel Tree. And she is going to stick around the Tri-Cities and practice general pediatrics with Ballad. So today she is going to talk about Prader-Willi syndrome, which is an awesome topic. So I will turn it over to Dr. Nichols.
Hi, everyone. So I picked this topic because I actually took care of my first patient with Prader-Willi syndrome this academic year. So, and it was with Dr. Ford. And so it was actually while I was on endocrine service. So it was a good experience. So first off, I have no disclosures, in case you were wondering. If anybody wants to give me anything, I'll take it. These are my learning objectives, and I tried to honor them in my presentation and honor them in my questions that I made. So recognizing the typical presentation and what symptoms to look for based on what age the patient is, figure out how to diagnose it, figure out how to do the core therapies and treatments, and be familiar with how to follow up the patients to make sure they're getting the services they need from all the other providers involved, and then what anticipatory guidance to give. So overall, Prader-Willi is a rare disorder, which I would assume is why I've only stumbled upon it once so far. So it's a neurodevelopmental disorder that has a whole slew of endocrine disorders from hypothalamic issues, developmental delays, and then kind of is most notably known for the infantile hypotonia and then the hyperphagia that develops. It was first described in 1958, actually, by Andrea Prader, a Swiss pediatrician, in collaboration with a guy named Dr. Willi, his first name's too hard, that was the head of a newborn nursery, and then a Alexis Labhart that was an endocrinologist in private practice. So to some people, it's known as Prader-Willi Labhart syndrome. And they published a paper in 1956, but it was in a small Swiss journal that is in German, and there's not even an English version of it because I looked. And then the name has basically been changed to Prader-Willi syndrome. It happens in all ethnic groups. Most cases are sporadic. It's about the equal incidence in males and females. It does disproportionately affect more Caucasians, but can be seen in all types. And then it was the first recognized disorder of genomic imprinting, or the first disorder we knew that was caused by that. That's what I'm saying. So its presentation is usually based on cardinal clinical features that people are aware of, and it's infantile hypotonia, developmental delay that changes into intellectual disability, craniofacial anomalies, growth hormone deficiency, hypogonadism, behavior problems, and hyperphagia that leads to obesity. Historically, it's in 2 clinical stages. So if you just had to have one way that you wanted to try to remember it, it's basically you have failure to thrive with hypotonia as an infant, and then you have hyperphagia and obesity later in life, if you need the simplest definition. It's been further described to actually have 7 nutritional phases for the people who study it. And so this is what that looks like on a graph version of that. So phase 0 is that individuals with Prader-Willi demonstrate decreased fetal movements, often with polyhydramnios and breech presentation is associated, and then have failure to thrive and severe hypotonia, basically in utero and at birth. Phase 1A is the basically 0 to 9 months, so the beginning of infancy. They continue to have hypotonia, continue to have failure to thrive. They have difficulty feeding, and difficulty feeding is often said to be it requires a feeding tube or a special positioning or special nipples. Phase 1B is the 9 to 25 month period, and it's basically a 17-month period of somewhat normal development and actually normal growth. The feeding problems are getting much better. Usually the tubes can be removed by this point. Phase 2A is the 2 to 4.5 years. The patient actually begins to develop features of metabolic syndrome and some weight gain, even though they actually usually don't show their clinical symptom of hyperphagia, which is interesting. And that's because of their metabolic problems at baseline. And in fact, at that time period, they will become obese even if you feed them what you would feed a normal child of that age. Phase 2B is the 4.5 to 8 years of age. The patients then actually develop like very clinically recognizable hyperphagia and hyperphagia behaviors. And they still have, though, like some satiety left that they can experience, but they have increasing weight and obesity if it's not controlled. Phase 3 is 8 years through adulthood. And basically the patient's metabolic syndrome and hyperphagia actually worsen. And it even peaks around this time, but that's obviously a huge range of age. And so obesity can develop. And in some people during the stage of 8 years to adulthood, which is huge, it can almost be impossible to satiate a patient. They may not be able to experience satiety at all. As older adults, the hyperphagia drive begins to decrease, and some patients become able to have satiety again, and some regain better behavioral control, like over their behavioral problems. So the first hallmark feature we'll talk about is fetal and infantile hypotonia. So this is a picture of a baby that has Prader-Willi from a different country, but it would look the same here as it does there. So you see basically the hypotonia is like, you know, obviously the kind of classic way in a picture is like when you turn the baby over and they kind of turn into like that upside down U shape. But then even the baby, for a term baby, shouldn't be laying like that on their back, right? So our hips should be up and kind of onto ourselves. Our hands should be up and onto ourselves or even curled in. So they won't have tone for the gestational age that they are. They also can have hypoarousal or just be kind of like sleepy or difficult to wake up. They can have a weak cry, they have a poor suck, and thus all those things basically make feeding difficulties. So if you can't wake up, you don't have good tone, you don't have a good suck, then you're not going to be a good eater. Like this kid, there's an OG2 that's present, which is pretty classic. The next hallmark feature is the craniofacial findings. So on the right is a 9-month-old female that has Prader-Willi syndrome, and she has, you can see like the narrow bifrontal diameter. She has almond-shaped eyes. I think that's even more obvious than the older child does. They could describe a flaccid appearing face, which I think is hard. I mean, she looks expressionless, but you know, that's a still image. They all have downturned corners of the mouth, which you can see in both kiddos, and then a small chin and short neck. And then you can even see her like she's had a G2 due to her feeding difficulties. And then even at her age, like as an older infant, she still has some hypotonia, they say like at baseline, and like kind of lays with her legs out. The left is an older child around, I think it's like age 8, that you can still see like the almond shaped eyes, the downturned mouth, and then you can still see the kind of the short neck. And then as is pretty obvious in that picture, you can already see his overweight that's actually probably likely obese at that point, you know, without knowing more about him. So the next hallmark feature is hypogonadism. So it's a consistent feature in both males and females who are Prader-Willi. It's a variety of how it manifests itself to meet that definition. So it includes like genital hypoplasia evident at birth, delayed or incomplete puberty, and then it causes or is causing infertility in most patients. So genital hypoplasia in females on your exam can just be clitoral and labial minora hypoplasia. And they say in multiple articles that that can be easily overlooked on a physical assessment on the newborn period, because as you know, like in our little bit like late term or preterm infants, you actually do have kind of an enlarged kind of clitoris look to it and enlarged, but in term babies, it may not be that remarkable. And so to recognize hypoplasia is not a skill I don't think that most of us would have to say, oh, that means that this child might have Prader-Willi. Genital hypoplasia in males, for what you should look for, is the most common is cryptorganism, and it happens in 80 to 90% of males with Prader-Willi syndrome. So I do think it's reasonable if you saw someone with cryptorganism to at least know that that happens in Prader-Willi syndrome. It can be unilateral, bilateral. Males affected can also have like a poorly rugated or an underpigmented or a hypoplastic scrotum or even a smaller penis size. For the delayed or incomplete puberty, it occurs in most patients, but then yet to throw everything off, 15 to 30% can actually have precocious adrenarche, even though they don't necessarily have puberty on time. And they think that's actually probably more likely to their obesity related. That kind of picture, like basically just adrenal exposure to insulin and IGF-1 from their obesity. And 4% can even have precocious puberty. So that's a little back and forth. Many patients require hormone treatment to have onset of puberty when they should by age match standards, to continue their puberty and to continue it at any point throughout their life if you want them to continue to have like regular puberty or normal levels of their sex hormones. There are no cases of paternity from a male Prader-Willi patient, but there has been 4 pregnancies reported from female Prader-Willi syndrome patients, 2 normal outcomes and 2 infants with an outcome of Angelman syndrome. So infertility is affecting most, and I would say probably all males, but there's a small chance a female could technically maybe have maternity. So hypogonadism was classically thought to be hypothalamic in origin because basically if you like lump everything together, there's like hypothalamic dysfunction in Prader-Willi syndrome, but there is more recent evidence that also there might be just primary gonadal failure in both, that the ovaries and testes also do not basically make what you would expect them to be making, even when given the opportunity, even when they are functioning. Another hallmark feature of course is a hyperphagia. So this is seen in all patients. This isn't just some or 90%, like this should really be in all patients. It begins in stage 2B usually. So around 4.5 years is when like the symptom of hyperphagia begins. Like I said, that overweight can actually begin before that. It worsens by age 8, it worsens through adolescence. That's when it peaks. It's basically described as like a constant and inexorable hunger that cannot be satisfied, which sounds about as sad as it can sound. It leads basically to excessive eating and behavioral problems and problematic behaviors about food. And then they've even done like functional MRI studies to confirm that there is decreased satiety signals where they would think an increased reward responses to food that kind of correlate to the kind of messed up system. And the excessive eating and hunger basically leads to like behaviors like hoarding food, stealing food, eating non-food items, like going garbage diving, like depending on how functional and how delayed they are, like how much they could actually help themselves or get into something. So another hallmark feature, obviously, when you have hyperphagia is probably that you have elevated weight. So this study for multiple sources actually says like 40%. I don't know if that's true, honestly. That just seems really low. I agree that with good treatment, it can be a low prevalence, but it's pretty high. It's definitely almost 100% in adults though. And whether that's just because it's harder to control the longer you live with it, or maybe our adult colleagues, or once they're out of the supervision of maybe their primary caregivers when they're children, just don't have as good a control. But like the adult estimates are like 82 to 98% are overweight or obese that have it. Weight can trend upward as a young toddler before that hyperphagia begins. Many patients will weigh twice or more their ideal body weight if they're untreated or have an uncontrolled diet. It is interesting that the obesity that Prader-Willi syndrome experiences is a little bit different from what they would call like simple obesity, like the obesity from just like excess calories that isn't related to a genetic condition. So metabolically, there's decreased muscle mass in people who have Prader-Willi and obesity compared to just like the less muscle mass you would see in someone with normal obesity. There's reduced resting energy expenditure in Prader-Willi syndrome obesity compared to like a BMI matched person with simple obesity. And then phenotypically, Prader-Willi syndrome patients.
May I have your attention, please? Medical alert, rapid response, courtyard outside of cafeteria.
Doesn't sound good.
May I have your attention, please? Medical alert, rapid response, courtyard outside of cafeteria. May I have your attention, please? Medical alert, rapid response, courtyard outside of cafeteria.
So phenotypically, it's also described that Prader-Willi syndrome a lot of times have like a higher distribution of fat in their proximal portions of all of their limbs and have lower visceral fat compared to a BMI matched person with obesity, which I will say is true for a patient. So like have very elevated increased kind of circumference of her upper arms and thighs, but actually had less truncal fat than you would think for someone with the same BMI, if that makes sense. So their body shape might be a little bit different. So the endocrine control of eating in a normal person is really complicated and is kind of an outcome of a complex input of hormones that tell you to eat and hormones that tell you not to eat. So orexigenic and anorexigenic hormones. And each of those things can be up, down, or normal compared to an unaffected individual when you look at Prader-Willi. So the orexigenic are the double outline circles. I don't know why they didn't like color code them differently. It doesn't make any sense. So the orexigenic are the double outline. The anorexigenic are the single outlines, like the ones that would tell you you're full and you don't need to eat. So they looked at all of these in a giant paper about obesity and Prader-Willi to try to look at each individual one and see, like, is it because these levels are up or down at the same? Basically, because if you could figure that out, maybe you could figure out a medication to give these people. So the outcome of looking at all these hormones are these few several things. Basically, that the orexigenic hormone ghrelin is very high in Prader-Willi syndrome, even in patients before they exhibit hyperphagia, and that might be a potential cause of their increased appetite and weight gain. That the anorexigenic hormone, the one that would tell you you don't need to eat, leptin, is also very high though in Prader-Willi syndrome patients, and that is expected. It's also very high in patients with obesity, so that doesn't really seem to be a causal relationship, because if anything, that would help them. And then the orexigenic hormone orexin, so I guess it was named first, acts as an appetite stimulator and is significantly higher in their plasma levels in Prader-Willi syndrome patients compared to even like unaffected siblings or unaffected people. So that also could contribute to the high appetite. But for most of these, it's unclear or it's not a causal relationship. So these are the ones that have the most kind of supporting evidence, and then leptin definitely does not have any help for explaining it. So one of the last hallmark features we'll talk about is the developmental delays and behavior problems. So this is also one of those things that's seen in all patients. It's just that it varies in exactly what it looks like or how it affects the individual. So the typical course is infants and toddlers have developmental delays, and then they end up usually with mild or even mild to moderate intellectual disability once they're old enough to have IQ testing. So the mean IQ is usually like 65 to 70, so it's in that kind of mild range. The behavior problems include manipulative behaviors, controlling behaviors, like extreme stubbornness, difficulties in changing routines. A lot of them have obsessive compulsive symptoms or even meet the diagnostic criteria to have like the OCD label. The key behavioral problems that I think people would talk to you about or ask you about like a test even would be like they have a high incidence of temper tantrums even into adolescence. Like they think that almost 90% of children and adolescents have temper tantrum problems, and then skin picking behaviors, because that's kind of specific to this disorder compared to other things. And that's thought to be related to just like the compulsive behavior. But that's very interesting about this disorder specifically. Brain MRIs have showed reduction in the cortical gyrus in their frontal, temporal, and parietal lobes. And those areas are kind of related to like verbal, like impairment or abilities, to IQ abilities. And the frontal parietal cortical areas have already been implicated in like memory, attention regulation, and language in normal people. So there definitely is some differences even anatomically in those areas that are important for behavior. So there's another hallmark feature of growth hormone deficiency. So there's a huge range in prevalence because it's a little bit complicated about kind of like how we diagnose it or who we do diagnostic testing on, but anywhere from like 40 to 100%, depending on how you look at how they define it. Patients present basically with short stature, abnormal body composition, and low IGF-1 levels, which is how anybody basically with growth hormone deficiency would present, right? And then patients, if you check kind of like their lab workup for it, they're going to have low IGF-1 and low IGF-BP3, which is what you would get. And then that's really because like growth hormone is an anabolic agent, and that it increases lean muscle mass and decreases fat mass and helps you grow. So when you don't have enough, you have the opposite things happen to you. Patients with Prader-Willi specifically can have even kind of almost clinically apparent low muscle mass, like even to the point that they almost seem like they have low muscle tone. And then they have increased fat mass compared to what you would see maybe in just someone who's just starting not to grow well. They can appear quite symptomatic from the growth hormone deficiency if they're untreated. And then in terms of using it to replace it, which we'll talk about later, if a patient with Prader-Willi has poor growth velocity, you can treat it kind of without even doing like a stimulation test, which we'll talk about. An associated feature, but not in everybody, is hypothyroidism. So it's another like my endocrine system doesn't work well, but its only prevalence is about 20 to 30%. It's central hypothyroidism, which means that it's an inappropriately normal TSH with a low total or free T4, which is not actually the typical type of hypothyroidism that we would think of or see. And then the prevalence of hypothyroidism in adults is kind of actually similar to their normal incidence. So it's actually not elevated. It's more of a risk during their childhood. And then testing usually at birth is normal. to the point that you don't need to check it right after they're born if they've had a newborn screen, because that's sufficient generally. And another associated feature that's not all the time is adrenal insufficiency. So the prevalence is a little bit unclear. It's ranging from like 15%, 60% in some studies. It occurs in both children and adults. It is also central due to their hypothalamic dysfunction. And the reason is that growth hormone actually inhibits 11-beta hydroxysteroid dehydrogenase type 1, and that helps convert active cortisol, that helps convert inactive cortisol to active cortisol. So they have a blunted stress response because of that. So, okay, so the genetic basis of like why this happens and the subtypes. So it is caused by lack of expression of paternally inherited imprinted genes on the 15th chromosome in like the region of Q11 to Q13. So normally the maternally derived alleles are silenced primarily by methylation, so that it leaves the paternally derived genes to be the ones that are active, because that's what basically imprinting is. It's like the genes whose expression is determined by the parent that contributed them. So it's a paternally inherited thing because the dad is the one who gets expressed. So in this picture, so the genes in blue are expressed only for the maternal chromosome in that section on chromosome 15. The genes in red are expressed only from the maternal chromosome, and the genes in black are basically like silent imprinted genes, and the genes in gray are exposed from like are biallelic or like are expressed by both parents. So this is all of the genes like looking at chromosome 15. So what happens with Prader-Willi is dad should be the gene, like in that region, dad's genes should be the only ones that are expressed. But if they don't get expressed for whatever reason, basically no one showed up from that part of the gene. Like you're not getting anything from anybody, if that makes sense. Like your moms are silenced or not there, and the dad's part that were supposed to show up to do their job didn't show up. So that can basically be like a deletion or several mechanisms. If this sounds at all familiar, it's because Angelman is kind of like the sister version of this, where the maternally imprinted genes in red are not expressed. So like it's like the other version of this, but the kids act different. Like they're the kids that like always are in a good mood, like always happy, laughing, but like have different dysmorphic features, are also developmentally delayed. So the mechanisms by how your paternally imprinted genes don't show up are basically you have a paternal deletion of 3 to 4 megabases in that specific region. So that's 70%. That is most of the people that's like what you would assume is wrong. Another good chunk of people are maternal uniparental disomy, where basically they only got an allele from their mom for both of their chromosome 15s. And so there was and both of them are basically silenced. So there's no paternally genes that are being transmitted. Or the least common kind of version is that there's an imprinting defect. So like they do get a copy from dad and a copy from mom, but the dad actually passes on his mom's version of an allele, if that makes kind of any sense. And so basically still both of your alleles are silenced. So it's rare. The reason why we kind of test to figure out what kind you have is it affects your inheritance pattern risk. So if this is how the child got Prader-Willi, is an imprinting defect, each subsequent pregnancy from that dad has a 50% recurrence rate risk compared to much less. So that's kind of why it would be important to know. So your diagnosis. So the mean age of diagnosis is like 3.9 to 4 years, but I mean, it can be made super young if there's like antenatal concern or suspicion. It's much earlier diagnosed than it used to be because molecular and genetic testing is like much more available and much more affordable. And then basically it can be a little hard to diagnose if you're not suspecting it from the beginning, because the signs and symptoms can actually be really non-specific and can evolve and kind of change over time before you catch on what's happening, so that you may not actually ever think about Prader-Willi syndrome in your patient. The first criteria for diagnosis were published in 1981, and they were just based off parental symptom reports for symptom prevalence on a pool of 100 patients. Because before that, there weren't clinical criteria at all, because it had been discovered 30 years before and they weren't sure. After that, there was a consensus guideline with criteria published in 1993 that was based on 113 patients because there was still really limited genetic testing and like cost was a big issue. And so it was just trying to help, let's test only the people we need to test and try to kind of not test people we don't need to test. By 2001, there was a revised criteria based on a like retrospective chart review and like patients who ended up being lab confirmed to try to further refine the clinical criteria to make it easier to use. So the first, we're not going to talk about the first criteria in 1981. It is the longest of all the criteria. It is basically every symptom that kind of occurred in basically a pool of 100 patients, and it's the longest. It's really interesting if you want to read it, but it doesn't necessarily help you know the most important stuff. So we're going to skip to 1993, which is the Home et al. Criteria, which is the ones kind of like the second most recent ones. So this not only was a smaller list, but it also like had a scoring system. So major criteria are 1 point apiece, minor criteria are half a point, and then supportive findings don't give you points. They just make you feel like it might be Prader-Willi. And then they even came up with like, depending on what your age, how many points you need. So for children 3 years of age or younger, you needed 5 points, 4 of which come from major. And for children 3 years of adulthood, you actually need more points. You need 8 points and 5 must be from major. So interesting things about this. So major criteria are basically the hallmark traits. So hypotony with poor feeding, feeding problems in infancy, rapid weight gain, characteristic facial features, hypogonadism, developmental delay, hyperphagia, and having a gene mutation in that area. So that makes sense. Minor criteria are other things that are more like associated, like decreased fetal movements, behavior problems, sleep disturbance, short stature, hypopigmentation, which is related to one of the genetic causes that can be associated with it. Narrow hands with a straight ulnar border, which you do see in some patients. So it just doesn't bridge out laterally if you're kind of looking down on the dorsal of their hand. Eye abnormalities, thick viscous saliva is something that comes up as a concern. Speech articulation defects and skin picking, like we talked about. Supportive findings that I think are maybe the most interesting about this, but don't get your points. High pain threshold, decrease in vomiting, temperature instability or altered temperature sensitivity, scoliosis and kyphosis, early adrenarche, osteoporosis, unusual skills with jigsaw puzzles, which I actually remember learning in medical school, and it apparently doesn't even get you a point. And then normal neuromuscular studies if you were doing that to try to figure out what was wrong. So then our last kind of version of clinical criteria were these. I'm not going to attempt to say his name and ruin it. It was in 1993 or in 2001, sorry, based on retrospective chart review of people who've been confirmed by genetic testing to have it versus like a kind of a mixed pool of clinical and genetic diagnosed patients. So instead of a point system, instead of anything, it was if you have these things, that's sufficient reason to test this person, which I think is a much, much, much easier thing to try to use in a clinical setting. So birth to 2 years, if someone has hypotonia and poor suck, it's sufficient to send Prader-Willi syndrome testing. From 2 to 6 years, if they had hypotonia with poor suck in their history and they have global developmental delay, that's sufficient. If you see the kid in their 6 to 12 and they had the history of hypotonia and suck, if they had a history of global developmental delay, and now they're showing excessive eating or obesity, that's a reason. And then 13 years of adulthood, like they now have, intellectual disability more as a diagnosis if they still have excessive eating and obesity, and they have like hypogonadism or typical behavior problems, that is alone enough reason basically to prompt testing. So as testing has become more available and more affordable and easier to do, our threshold has went down to kind of have this, to make the diagnosis and do the genetic testing. So if you get here and you want to test your patient, then what are you going to do? What are you going to order? So the first thing you're going to order is a DNA methylation analysis, or just called like a methylation analysis. So it's what you would consider like is the first line test. So you can do it different ways. So you can like how the test is ran can be different. So it can be done via PCR. It can be done via Southern blot. It can be done and a methylation specific multiplex ligation dependent probe, which has an acronym. I don't know, honestly, that I'm to the point that I could tell you which version of that test to order. I don't know. I'm sure there's a paper that can tell you that, or a geneticist that can tell you that. If that is negative, it's highly unlikely that it's Prader-Willi, and like basically, no matter what paper you look at, says like consider other causes. Some of them will give you other causes, like this graph does. Like it'll give you things like basically consider what's on the differential for Prader-Willi syndrome, like this table does. If it's positive, then you basically move on to figure out the genetic subtype, like we talked about before, like to figure out the mechanism that caused it to happen in the first place. So that's like the second test if you have confirmation. So you can either do a FISH or a microarray first, basically, and then if you need to, go into a DNA polymorphism. So a FISH is classically what was done, right? FISH existed well before microarrays. It's cheaper, it's faster. I don't know if it's honestly faster depending on some of these microarrays, but it will pick up basically if it is if it's not a uniparental disomy. So it'll pick up the most typical thing, which is there's a paternal deletion. So obviously, as you would think, a microarray is a little bit more sensitive, right? It can pick up smaller things than a FISH, but still a FISH is kind of like what was typically used. And then if you have a positive DNA methylation assay, but you can't find a deletion on your chromosome microarray or FISH, then you send a DNA polymorphism assay to figure out if it's uniparental disomy from mom or if it's an imprinting defect. And like I said, the reason is not that you have to further prove that they have it, because you've already proved that they have Prader-Willi by their methylation test. It's basically because there's some phenotypic varieties and maybe certain symptoms they get. And then it's also so that you can provide genetic counseling to the parents, because if you know how it happened, then you can try to talk to them about future pregnancies. So now that we've figured out our patient might have it and then actually diagnosed it, so let's talk about specific things you would do for the certain features of it. So first, for the infantile hypotonia and failure to thrive. So this is basically like any kid with any disorder that causes infantile hypotonia and failure to thrive, right? Like you just have to provide supportive care is really actually what it is. It's feeding support. So feeding support needs are almost universal in case of Prader-Willi. What that is usually considered to meet the definition is that you either need special positioning, special nipples, or you need like tube assisted feeding. Some of them actually have success with like a Haberman or a pigeon feeder nipple, which are actually nipples usually used for cleft palate, but apparently are sometimes helpful in these infants as well. And then the calorie needs for these infants can sometimes be below average if they're growing okay, because of the low metabolic rate, or if you're trying to catch up someone failing to thrive, then obviously you may actually need increased calories to get them back growing. And then you have to carefully kind of titrate their feeds and calories based on their growth rate in like very sequential close monitoring. As soon as kids are growing well, they advocate that you remove the tube because, I mean, it's not fun to have, it costs money, it requires constant care. And because really, right, it's a dichotomy kind of situation, like they're not going to need it long term because it's going to turn the other way. For the hypogonadism, basically, there's some literature that says actually starting human growth hormone treatment may help with testicular descent if there's cryptorganism, or even could increase your scrotal scalp or penile length. There's not literature about human growth hormone therapy helping the female hypogonadism features. Obviously, if you have cryptorganism, you have, surgical correction by a certain age is recommended. So for most people, that's before their first or second birthday, so before age 2. And then for onset and progression of puberty, basically most people require sex steroid replacement, or at least kind of like almost an induction of puberty with sex steroids. There can be benefits to sex steroids for this because it can improve your bone health and increase your muscle mass. Like kind of when you go through puberty, it changes like your body parameters. And then a lot of individuals have to have continued sex hormone replacement throughout their entire lives if they basically want to maintain the pediatric puberty or like maintain their periods or things like that. For their hyperphagia and obesity, the main things are that you need a prescribed diet. So your prescribed diet ideally should start almost as soon as they're born, in terms of like you need to be that on top of titrating their calories to their growth, but then really by 14 months, like you should have a prescribed diet that's very specific to that kid. So your diets per day are 10 kcals per centimeter length per day, and then a balance of macronutrients, not micronutrients. It's like, 40% carbohydrates, and then everything else is also balanced. For kids who get to pick what they eat, they want you to offer a wide variety of healthy food options, right? Because, at a certain point, like you don't want to eat the same thing every day. Like nobody wants to do that. And then there's this concept of food security, which I don't think I have ever heard in anything except Prader-Willi. And they say it's actually like not being the food police, but what it reminds me of is basically being the food police, but that it actually can bring comfort to the children who are anxious about food and can actually improve their hyperphagia if you implement food security. So it's made up of like two things. It's physical food security and psychological food security. So physical food security is like, you need to lock up your food. Like, you need to lock your fridge if they can open the fridge. You need to put food where they can't get it. They can't go out and find food in the garbage can, like literally, like physically secure your food. And then the psychological food security is basically something on the premise of it's called no doubt, no hope, and no disappointment. So there should be no doubt that the next meal is coming, how much they will get in their serving, or what type of food will be served. So like basically that is like in a way to meal planning, right? Like they know what's going to be served for lunch. They know every time they eat, I don't know, like Cheetos, they get this many Cheetos. Not that they probably should eat Cheetos, but, and then no hope is also called no chance. And that's basically there's no hope that they were ever going to get food outside of what is planned and outside of what is provided. Like there is no chance that they're going to get a 2 p.m. snack if they don't get 2 p.m. snacks. And then no disappointment, which means like you can't change the expectations or change the plans, right? Because that just sets up kind of like a mode of failure. Like you can't give in and say, just kidding, dinner was supposed to be at 6, but it's at 7 because I was busy. Because like a kid who has insatiable appetite just waited from 1 to 6 to eat, and now you're telling them another hour, and they already have a propensity for behavioral problems. And so basically you're going to set off a spiral. Like that could be actually like 10 out of 10 bad. And then they also need a daily physical activity, like just like every kid, right, should be getting like, 60, 120 minutes, I mean, every kid should be getting cardiac exercise every day. It's really important that these kids do, because like you need to try to prevent obesity. And then medications are a complicated topic. They have tried, there's lots, as you're aware, of like weight reduction kind of type medicines. Not all of them obviously have been studied in Prader-Willi syndrome patients. They've been studied in just adults. Some of them have been kids and adults, but not Prader-Willi even. So the most likely candidates look like metformin, maybe. It's been studied in adult patients with Prader-Willi, and it improves satiety and has been shown helpful. Topiramate has been used in kids and adults with Prader-Willi, and it does seem to cause less food-seeking behavior, and it actually improves their skin picking. And then the GLP-1 agonists, like the exenatide and liraglutide, can improve glycemic control, satiety, and reduce body weight in adult Prader-Willi syndrome patients. But like there is no medication that's obviously FDA approved for Prader-Willi syndrome patients for their weight. And there's not many that have had a lot of adequate pediatric studies yet from our perspective. Growth hormone therapy. So growth hormone therapy is probably the most common therapy type of topic that would come up for someone with Prader-Willi, because it's complicated and it's used for a lot of things if someone's going to ask you about it. So human growth hormone is not used for height, basically in this. That's what the FDA label says it's approved for. But really what people use it for is a bunch of other things too. So in the US, growth hormone is only FDA approved for Prader-Willi for growth failure that is caused by Prader-Willi syndrome. And it got that label in 2000. But in Europe, it says that, and it also is indicated for improvement in body composition, which, as you can imagine, allows much more people to be able to be prescribed it. Because growth hormone therapy, yes, it helps the short stature caused by the growth hormone deficiency, but it also very much improves their body habitus parameters, which is part of the problem in Prader-Willi. So it helps the most in their body composition the first year of therapy. It causes a lower body fat percentage, like we're talking like 36% versus 45% body fat. It causes improved muscle mass. It causes improved inspiratory muscle force, which is important, right? Because if you have weak muscles, then you're at risk for respiratory compromise, which is a big issue for them. It also causes improvement developmentally. So those who are treated for at least 1 to 2 years have significantly improved cognitive and motor development scores on like Bailey scales. Other studies have even shown stabilization of their IQ or even increases in IQ when they're treated, compared to the comparative group with an untreated population of Prader-Willi, where they actually saw decreases just over time in their IQ. They think that it may help cognition because basically human growth hormone has positive effects on brain development. It helps your head circumference grow, right, as well as everything else. And it also can help you interact in your learning environment when you have better motor function. And then it's been shown to help in behavioral improvement studies to help depressive symptoms, specifically in kids 11 years and older, Prader-Willi. And then also the study was also to show that like growth hormone didn't show a worsening of behavioral problems, and they're on it, like, right? So we don't want to like cause harm, like just to try to help something. So it has lots of other benefits. So there's a little bit of uncertainty about when to start. So like to get your FDA approval, you're probably going to have to say that they have basically poor growth. You can interpret that and apply that label in your chart as you wish. I feel like pediatric endocrinology is the person to do that. But it's optimal to start it prior to them ever becoming overweight, which for some patients actually means starting it before age 2. And some trials have included kids as young as 4 months of age in randomized controlled trials, and that's shown to be safe and effective. The duration of benefit, so the reason this question is, well, then how long do they stay on it? Well, that's also complicated. So we don't really know is the answer. Some people stop it before adulthood, right? Because typically you continue growth hormone until your growth plate's fused because you're using it for height, but you're not necessarily just using it for height. So if you, let's say you stop it when they're 6, I don't know, like when the girl is 16, 17 and her growth plates have fused, they actually have shown that the benefit can last for several years in those parameters, even off of growth hormone, but they eventually tend to fade. Those effects on body composition and those effects on kind of development. And then the question then is, you know, well, then what are the risks or benefits? Like, you know, it's a daily injection, it's expensive, it causes all these benefits, but there are inherent risks using growth hormone in normal kids and kids with Prader-Willi. So there are contraindications based on pharmaceutical research and kind of expert consensus. Some of these have been added to their box as a box warning. So the contraindications are severe obesity, untreated severe sleep apnea, uncontrolled diabetes, active malignancy, and active psychosis. So like you definitely don't want to be prescribing that if one of those things are present. So what are the concerns really about? So the concerns are that we found when we gave kids with Prader-Willi syndrome growth hormone, they had unexpectedly high IGF-1 levels, even though like higher than what you would think for that dose. So everyone's IGF-1 levels should go up when you give growth hormone because like that needs to go up because that tells them to grow, but theirs went above what they would expect. So there's been all these potential concerns that maybe these excessively high IGF-1 levels could actually also stimulate lymphoid hyperplasia. And if you stimulate lymphoid hyperplasia, then you stimulate, right, like things like your tonsils and your adenoids. And that if these patients are already at risk for sleep apnea because of their weak muscles, or some people have like nocturnal hypoventilation when they're Prader-Willi, or they have scoliosis, then if you also make their tonsils and adenoids big, or like their lymphoid tissue in their neck in general, they may have more sleep apnea, and that obviously can increase your risk of death. Or if you stimulate lymphoid tissue in general, like could you cause a malignancy? Is there a higher risk of malignancy? There's actually no clear recommendation for like what to do about the IGF-1 levels because we don't know what to do about them. The goal is you should probably, expert opinion is you should check them every 6 to 12 months if you're the one prescribing it, like which would probably be Peds Endo. And then your goal should be to keep the IGF-1 levels between 1+ and 2+ standard deviations and like not above that 2+. But the problem is that you also want the dose of your medicine to be high enough to be what's shown to be effective, right? If you're giving it. So the kind of minimum dose to achieve the body composition effects for most patients is 1 milligram per meter squared per day. So the real conundrum comes when you're trying to get to optimal dosing, but yet you're having to pull back because of the IGF-1 levels. And so that's a complicated place to be in. Human growth hormone for other people and other studies has been shown to increase insulin resistance, but pediatric studies have shown no significant changes in glucose homeostasis, even up to 4 years of therapy. But there are adult studies that can show that it might over time increase your fasting glucose, but not even change your hemoglobin A1C, because we're like trying to prevent as much adverse effect as possible. Basically, you're supposed to do metabolic surveillance for diabetes if you're over 12 and on growth hormone therapy, which we'll talk about in a minute. And then there's concerns about sudden death. So this is another like kind of like quagmire of information about this. So there was a study of Prader-Willi syndrome patients that were treated with growth hormone from 2002 and 2006 compared to people who weren't, and there were 20 deaths in the treated patient group. And so they thought, like, is that a little bit more in that group because they're on growth hormone? It could have been a lot of other reasons, but In another review of 64 cases of death in children with Prader-Willi, 44% were receiving human growth hormone at the time of death, so about half. There was no differences in like the cause of death if you compared those who were on treatment, those were not. But I think the real kicker that got people's attention was 75% of the deaths in the growth hormone treated group occurred within 9 months of starting therapy. And so I think they don't necessarily know that it's causal, but yet it did seem temporally related to starting it. So that's why there's this big thing about if it might be the lymphoid hyperplasia thing, then you need to make sure that you've addressed like the sleep apnea component of it. And while like one of the contraindications is severe untreated sleep apnea. And that it also, and then like one of the other hypotheses is that it might increase your risk of developing central adrenal insufficiency, and that like that could precipitate that, and that could lead to like more risk of death. So speaking of sleep disorders, so there's a super high incidence of sleep disorder breathing, or even to the point of central or obstructive sleep apnea. So it doesn't even just have to be obstructive from their weight, it can also be central, so that's complicated. And then it can also even be that it's their lungs a problem, right? Like you can have sleep apnea because you're obese, or you can have difficulty breathing and ventilation because of your restricted lung disease. So they have muscle weakness, which can technically be to the point that it's restricted lung disease. They also have a high incidence of spinal deformities, which can cause restricted lung disease. And then they have a reductive ventilatory response to hypercapnia in a lot of patients, even at baseline, who don't even have sleep apnea. So they can even have like chronic hypoxia and a little bit of chronic hypercapnia. So then there's that thought that human growth hormone could potentially worsen your sleep disorder breathing or sleep apnea, or even cause like lymphoid hyperplasia, the worsening of the obstructive portion. And so it's just a little bit of a mixed bag. They've looked into the point that there's even been a study that showed that patients who received treatment had improvement in their central sleep apnea if they had it, but had increased obstructive sleep apnea on their AHI index. So I'm also not sure how to balance like making your central better if you have it, but yeah, I could make your obstructive symptoms worse. So because of that, like prior to starting growth hormone in a patient, you have to evaluate clinically for sleep disorder breathing, like on symptoms, but also if anyone thinks you have sleep disorder breathing, if there's a history of snoring, if there's enlarged tonsils or adenoids, you're supposed to refer to ENT to have a TNA beforehand. You're supposed to refer to pulmonology or sleep clinic for sleep oximetry while sleeping in all patients, preferably to do like a full sleep study even. And then if OSA is present, you need to start treatment before you initiate it, and then follow up with like a repeat sleep study to see if you made it any worse after you start growth hormone. Adrenal insufficiency is something that comes up like when you're caring for them, because there's no really clear consensus on evaluation or management, because it's a little bit hard to decide who has it based on what expert opinion you use. Some people recommend obtaining a cortisol and ACTH during illness or stress to try to clarify if you truly want to label them as adrenal insufficient, which for our patient they did. They came in with another illness. So it's like, well, while they're in a stressful situation, let's get an ACTH and cortisol to try to figure out, is this someone we need to treat or not? So because certain groups recommend stress dose steroids for all patients with Prader-Willi, for all illnesses, even including URIs, regardless if they've had a diagnostic kind of stimulation test that shows it. And then others basically say, no, we should just stress dose all patients when they're under certain triggers, like perioperatively, like for a major surgery, everyone warrants it. And then some people say, no, I'm more risk tolerant. I only want to give it if the lab workup suggests it. And ideally, like I collected these labs under stress, or I did a provocative test. So that's a little bit different about, it would kind of almost be endocrinologist dependent about if your patients were even stress dose kind of without the formal diagnosis, if they still had that at home in case. Spine deformities kind of vary in prevalence pretty big, but there's a 70% cumulative lifetime risk that if you have Prader-Willi syndrome, you're going to have a spinal deformity. Now, it's most commonly scoliosis, but it also can be kyphosis or in the mixed picture. So it's kind of caused pretty intensive screening recommendations. So when the child can first and independently, you should start thinking about scoliosis, which is obviously much sooner than you would ever think about scoliosis typically in a normal person. Because they can have almost hypotonia-driven kyphosis and scoliosis because they can't keep their spine straight. And then from the moment that they can sit independently until 4 years of age, every year they should have scoliosis films and like spinal curvature films. And then if it's present, you should refer them to an orthopedic surgeon. The treatment, like I said, like you decide to intervene with bracing or surgery, is not really because you want to protect their body image, but because they can have like the respiratory status compromised because of it. So what kind of things are you going to do at a visit, and what kind of things are you going to tell them now that, you know, you've had them, you've done all the things? So at like the birth to 1 month visit, the things you need to do is like, you need to make sure the genetic diagnosis was made, or like the testing is pending, like to make sure that is on the books, you understand what kind it is and what's happening. Your history needs to focus on feeding, development, and then concerns for sleep apnea or apnea-like behavior. And then on your exam, you need to kind of pay attention to the hypotonia, and then pay attention to hypogonadism, specifically in males, to be able to follow that over time if it's cryptorganism. So what you're going to talk about at that visit is basically talk about the clinical manifestations of the disease with the parents, talk about the challenge that's going to happen of like, there's difficulty feeding now, and then there's going to be an issue where they eat too much later, so that they know that switch is going to happen. That you want their feeds to be 20 minutes or less, that you only want to have to use kind of tube feeds if you need them, or only place it if you need it. You need to refer them to early intervention services as soon as you can, and then provide them with support, you know, whether it's support groups, and then kind of talk about the recurrence risk based on the genetics up top, if you know they haven't seen genetic counseling in case they're planning for future children. So during the infancy period, you need to make sure, like I said, that genetic diagnosis was made. You need to pay close attention to kind of their growth over like subsequent visits, using the growth charts, kind of assess their daily calorie intake and titrate it to their growth. And then in males, like I said, you know, if you had undescending testes or an inguinal hernia, kind of thinking about, is this kid going to start on human growth hormone, and we can see if that helps, or are they going to get to that age where we have to surgically correct it? Of course, you're still going to do developmental history and routine vaccinations and eye exam at every visit. For what to talk about at those visits, so you need to kind of talk about the feeding issues, their growth, the development, if they're having developmental delays. Already start talking about the benefits and risk of growth hormone therapy, and if they're interested, and you know, refer them to pediatric endocrinology if they're not already, for them to have that discussion as well. Talk about the probability of kind of what their developmental outcome is going to look like. You know, this kid was likely to have mild to moderate cognitive impairment. And then try to figure out if in addition to early intervention, do you need to be doing additional kind of very specific therapy referrals? So the 1 to 5 age, again, basically for all their life, it's going to some degree focus on diet, their growth, and their development. So there are Prader-Willi specific growth curves from like age 1, like after the infancy, but you actually only use them if they're not on growth hormone treatment. If they're on growth hormone treatment, they recommend using normal ones. So making sure you're looking at the right growth curves, talking about their dietary needs based on their growth rate, like using a dietitian if you need that. They need a formal hearing by an audiologist and a formal vision assessment by an ophthalmologist before age 3 is the recommended care by AAP for them. And even sooner, if you had concerns, like let's say you had nystagmus on exam, you know, or you had concerns like that, then earlier. You need to evaluate for scoliosis from the time they're sitting independently through age 4, with yearly films through age 4, and then clinically only after age 4. You need to evaluate for sleep disorder breathing clinically, and then refer them if needed. They need to see a dentist ideally by age 1, which is a hard sell for anybody, and then actually have cleanings, they say every 3 to 6 months, because they're thick saliva, they have impaired salivation, and that they have increased dental caries risk. And then thyroid function testing begins annually, basically at 1 to 2 years of life, as long as they've had a normal newborn screen. So your anticipated guidance for the 1 to 5-year-olds, are you're going to talk about like transitioning their early intervention therapies to like a school-based, like pre-K kindergarten therapies, talk about specific problem behaviors. So like that 4 to 5, they're starting to have definitely like eating kind of driven behaviors, and then obviously like temper tantrums and all that has already happened. And then kind of emphasis need for their adherence in diet and their prescribed physical activity by all caregivers. So that means like every therapist involved and every teacher involved to kind of adhere to what you need them to do. And then for older children and adolescents, your health supervision is going to focus again on development, behavior, and growth. You're going to still evaluate for scoliosis. You're going to then start talking about like there's premature adrenarche risk, but then figuring out if they're at risk for delayed puberty, and if they are they going to go into puberty from your perspective. Monitoring for sleep disorder breathing and apnea. Continue your thyroid function annually, and then if they're on growth hormone and they're 12 years or above, you then start adding on like screening for diabetes. There's not a clear recommendation on what to use. Hemoglobin A1C would be fine if you don't want to have them to be fasting. And then also, this is kind of the age where mental health problems start to happen for any kid, but these kids are at increased risk of mood disorders or at increased risk of psychosis specifically. And so you also need to start having that on your radar, and then also talking to your parents about it. So continue talking about dietary restrictions and daily exercise, talk to the families about puberty and menarche and like contraception plans, especially in the females. discuss behavioral management and recognition of mood disorder for the parents to be looking out for, and then kind of talk about school performance and like what kind of educational setting they're in, and if they would be able to pursue kind of vocational training based on their ability level, and then what their future plan is for their caregivers. So the prognosis. So the life expectancy is a huge range. So this is using a Prader-Willi Syndrome Association database from the US. It's from 1973 to 2015. And the mean age of death was 30 years, basically, plus or minus 16 years. The actual range was 2 months to 67 years. So, and then I think the best news about all of it is that the life expectancy is increasing over time. So as we understand it better, we're able to diagnose it better, and then we have better medical interventions, like our life expectancy for these children has improved. The most common cause of death is respiratory failure, that's 31%. Heart disease is 16%. The third is a GI event. It's usually perforation or obstruction, and that's actually usually related to binge eating episodes, to the point that it can cause perforation, necrosis of your bowel, and then necrosis. And then a notable minority of deaths, in 6%, are actually due to choking events, usually in the younger age, related to hyperphagia. So your prognosis is most improved basically by preventing obesity or resolving obesity, so that you don't get obesity like related complications, just like any person with obesity would have, like the sleep apnea, the heart disease, things like that. And then the earlier we can diagnose it and the earlier we can treat it, the better basically their outcomes can be. So, thank you guys. Here are my references. Thank you to Dr. Ford for helping me take care of this patient. You guys have any questions? Thank you guys.
Nice
Thanks,
job,
Sarah.
Sarah.
We don't have questions because it's such a beautiful, thorough review. Thanks for an awesome job.
Thank you guys. Okay, I'm gonna stop screen sharing, I think. Pause share. Thank you, Dr. Lewis. I just saw your chat. Okay. Okay, bye guys. Have a good day.
Bye.
Leave, I think. I'm not sure if I actually got how to leave. Okay, leave.